Good morning. Today our discussion will be about excessive irregular menstruation. In the medical term, this is called menorrhagia. This is when women go through phases of no bleeding that may last for 2 or more months, and other phases where she have either spotting or episodes of bleeding. Irregular bleeding most often is related to abnormal ovulation, or what is known as polycystic ovarian syndrome. Evaluating any patient that comes with heavy irregular period, she should consult a doctor. It has a lot of ramification. If the patient assumes that it's going to be okay without the consultation, she might end up having severe bleeding, irregular bleeding, and the most bad one is to have anemia. So she should consult with her doctor. In the evaluation, we have to consider the woman's pattern of bleeding and her medical history, physical history, as well as pelvic exam. Additional testing will be based on the evaluation, which could include the pregnancy test, hormone profile test, ultrasound, biopsy called endometrial biopsy, which is a sample taken from the lining of the womb to see at what stage the uterus of under the influence of estrogen, and pap smear. Once the cause of the bleeding is determined, treatment can be tailored according to the patient problem. I hope you have to go through this kind of like scheme of how to deal with patients that have irregular uterine bleeding. It could be cyclical, predictable, or unpredictable. The cyclical could be heavy menstrual bleeding or intermenstrual bleeding. And the heavy bleeding could be adenomyosis, where the lining of the uterus infiltrates through the myometrium, the muscles of the uterus, and results in enlargement and heavy bleeding and all the rest of it. Submucosal fibroid, coagulopathy difficulty, or insufficiency of certain coagulation factor, or endometrial cancer. Intermenstrual bleeding, look for the polyps, could be iatrogenic, meaning some medication given that was not taken properly, or there is unpredictable. The abnormal uterine bleeding and intermenstrual bleeding, as we call this, could be polyp, adenomyosis, leiomyosis, malignancy, and hyperplasia of the endometrial lining. Others could be coagulopathy, ovarian dysfunction, endometrial problem, iatrogenic, and that is medication prescribed to the patient. The menstrual disorders include menorrhagia, which is regular heavy period, dysmenorrhea, painful period, amenorrhea, oligmenorrhea, which is when there is no period at all, or period that involves a slight spotting, polycystic ovary disease, postmenopausal bleeding, and premenstrual tension. The classic terms are still in use and need definition. Menorrhagia, as we said, is excessive loss of blood, more than 80 ml. I bet half of us lose more than 80 ml in a cycle. Regular menstruation, metrorrhagia, prolonged heavy bleeding from the uterus, metromenourhagia, heavy and prolonged, polymenorrhea, frequent menstruation. Menorrhagia, as we said, it's heavy regular menstrual bleeding, and the loss will be higher than 80 ml. The 80 ml is not used in practice, just in research. This definition is rather arbitrary, but represents the level of blood loss that results in fall of hemoglobin and hematocrit concentration. The menorrhagia is extremely common, and it affects about more than 5% of the women in the United States. The age will be between 30 to 49, and the patient needs to consult with their family physician. The causes generally are thyroid in 5% of cases. There is coagulation disorder, von Willebrand disease with hereditary disorder of blood coagulation, leukemia. Sometimes there is pelvic pathology in 35% of cases, dysfunctional uterine bleeding, which is irregularity due to hormone abnormality, advanced liver disease, and that can be spotted from the patient history, drugs like warfarin and heparin. If we want to approach a patient with heavy bleeding, we need to take the history, which is very important. The history of regular excessive heavy blood loss over several months or over consecutive cycles is largely a subjective definition, and it can be hard for the woman to communicate in words how much blood she lost. Discussion of the numbers. Talking about number of towels used, tampon, that get drenched with blood is maybe a parameter of how heavy she is bleeding. It's also important to determine the duration of the current problem and any other symptoms of potential importance. The other symptoms that might suggest dysfunctional bleeding, which is due to hormonal irregularity, postcoital bleeding, which is bleeding after intercourse, sudden change in symptoms, dyspareunia, pelvic pain, premenstrual pain. These are all suggestive of problem. Excessive heavy bleeding following procedures like dental extraction. Examining the patient. Also, the history should involve thyroid disease, history of coagulation problem, irregular intake of contraceptive pill or hormonal medication. Patient general condition should be assessed: height and weight, vitals, thyroid, examination of lymph node, axillary, inguinal, breast examination, abdominal pelvic mass, and ascites should be ruled out. Pelvic exam should involve the speculum and bimanual. Bimanual meaning examination of the uterus and the abdomen at the same time. The investigation, hemoglobin, the complete blood count, which involves hemoglobin platelet, pelvic ultrasound, preferable, endometrial lining thickness, presence or absence of an axial mass, cervical smear, hysteroscope, and endometrial biopsy. This is mandatory after the age of 40. Others recording specific problem. The treatment is divided into three categories: when the patient is less than 20 years old, more than 40, between 20 to 40. The medical treatment, there's a medical, non-hormonal, and hormonal. The non-hormonal is using medication like derivative of ibuprofen. It's called mefenamic acid, and it's taken 2 days, tablets 2 days prior to the period and during the period. This will act against the prostaglandin, and that is released and causing pain and heavy bleeding. So the period will be less painful, less clot formation, and the advantage of this method is that the patient, first of all, is not using a hormone, as many patients refuse to use hormones. Second, you'll be the doctor of yourself. If you see that the bleeding is not there, not that heavy, there's no pain, you can skip this medication. Otherwise, you can take it just before, 2 days prior to the period and during the period, and it'll make a lot of difference. This involves many different medication that we do not want to bother you with. Then this is the non-hormonal. The hormonal depends on the patient age. For those who are less than 20 years old, birth control, oral contraceptive pill will help a great deal in regulating the pituitary, hypothalamic, ovarian axis, and regulate the hormonal release. Also, we have between the age of 20 to 40, we can use danazole, which is an anti-androgenic, GnRH analog. This is advanced medication, and this cannot be taken lightly. It should be prescribed after intensive investigation confirming the cause of the heavy bleeding. After the age of 40, between 20 and 40, there are two lines of management. As we spoke about teenagers on oral contraceptive, women approaching 40 with irregular heavy bleeding, we can use levonorgestrel, releasing intrauterine contraceptive device, which is what's called Mirena. And this has two advantages. First of all, it releases hormones on regular basis, daily, and it can be effective for 5 years, during which the patient will be able to recover her blood count and hemoglobin fall, as well as it provide birth control. It's very effective, and it releases about 20% of levonorgestrel microgram a day. Also, it decreases the incidence of pelvic inflammatory disease. It does not increase the risk of ectopic pregnancy. Surgical treatment is, there are many types of surgical treatment. Now, the most important part is all of them are important, but postmenopausal bleeding after menopause, when the patient have irregular bleeding, she should be investigated thoroughly, fearing of endometrial cancer. The patient needs to have ultrasound, endometrial biopsy, height and weight, and then a hysteroscope, and then dilatation and curettage, and having pieces of endometrial lining to see the structure of the endometrial lining. Then, depending on the results, if it is benign, there are many ways of ablation of the endometrial lining, either laser or other forms of medication, other form of procedure, or if it indicates any form of cancerous, then the hysterectomy and referral to the cancer center. This is a wide subject. I just had to give the headlines. The main influence of this lecture, out of this lecture, that I aim for is to be aware of the fact that if the period is irregular and or heavy at any age, it should be checked by the family physician and referral to the appropriate center. Have a great day. This brings us to the end of the dictation.